calories or carbs, what to restrict in diabetes. I welcome Dr. Arun Viswanath, yes, MDDM. He did his MBBS in Madurai Medical College, MD at Aligarh University, and DM at Srinagar, Jammu and Kashmir. His area of interest is type 1 diabetes. So I request Dr. Arun and over to Dr.
I was your student, you may not remember me.
Yes, it's my student, it's MBBS.
Very good morning, everyone. I thank Honorable Sir for the opportunity, and if you have some time, at least visit SAR Center. He is the living example how to incorporate NEAT in routine practice, non-exercise activity analysis. Because he has 3 or 4 chambers, he loads patient in each of his chambers and he wants every time to see the patients, right? So carbs or calories, what to restrict in diabetes, right? So some of you might be actually feeling this more of a rhetoric questions, right? What is there to discuss? Yeah, let's restrict every damn thing in the life of a patient with diabetes. What is there to discuss, right? And I remembered this famous meme template from Chennai 28. After winning that task, the minister asked, are you going to opt for fielding or bowling, right? So similarly, for carbs or calories, let's restrict everything. So that some of you might actually think in that way. So the idea of my presentation is to complicate things for a change and let you know that it's not a straightforward answer, right? So what to eat? The $1,000,000 question that most of our diabetes patients ask, especially they'll be, even if you're trying to explain diet, most of us will be having a one-to-one discussion if you're trying to explain diet for a million times. Even the next time when they visit, before they leave, they always ask what to eat, right? So that explains the complexity of diet. Apart from our shortcoming on their, when probably the presumed lack of awareness or lack of understanding, the diet itself is a very complex thing that depends on a lot of factors. Apart from we talk about carbs and the macronutrient, how we cook them and what are the foods available and what is the type of pattern that we are trying to insist in our patient. So leave that alone. All the other factors, external factors, availability of food, socioeconomic factors. There's simply put, there's too much things or too many variables to completely explain a diet in a one-to-one discussion. That's why they say that we should have trained educators. Unfortunately, most of the places we don't have them. I don't have them, right? But despite all this complexity, diet and exercise remains the foundation, even though we don't lay that foundation solidly in most of our patients. So irrespective of the beautiful treatment charts that we prepare, most of the time when, as Vadivel says, the foundation is weak, the building will not be strong, right? So over the years, diabetes, we know diet plays an important role in diabetes care. Right from ancient times, we know that anything, as Sushruta says, anything that comes near tasting sweet, we just stop the things. And that was more refined by Thomas Willis, you restrict all kind of carbs. Then came John Rollo, who proposed meat diet. Then William Osler famously said abstain from all fruits and garden stuff. Then Alan introduced starvation therapy, which Professor Jocelyn probably adopted in a different way. So all these therapies that we talk about had been actually one of the breakthrough in that time because there was no drugs. Now after nearly 100 years of insulin discovery, we have a lot of drugs, and if you think deeply, we are still saying the same thing. Majority of us will say abstain from all sweets or abstain from all kind of foods, and there are some famous one-liners. Anything that grows under the soil, we should avoid. 3 white poisons of life. All these things I heard from the patients. And probably we also play some role in propagating this one-liners, right? So as they say that exercise and diet is a form of therapy that we start with. It's a first-line therapy. It's the first-line drug that we try to incorporate. That's why the name medical nutrition therapy. Diabetic diet is an obsolete word, and I feel it's an offensive word as well, so please don't use them. And by definition, it is a systematic approach to optimizing dietary intake to achieve our goal in patients with diabetes. So when we say therapy, all the fancy yet soulless words that we use like individualized care, multidisciplinary effort, and holistic approach, all these things, all this principle actually applies to diet and exercise as well. You not only don't want to get a glycemic control with your diet, we want them to have long-lasting weight reduction, long-lasting cardiorenal benefit, long-lasting risk reduction, multifactorial risk reduction. All these things should also be the target of our diet therapy or medical nutrition therapy. So modern principles of modern MNT. I hope it's modern enough. So they say that we have to promote and support healthful eating pattern to achieve not only glycemic goals but also to reduce your cholesterol, BP, and also to prevent long run cardiovascular benefits as well. It has to be individually sensitive to the cultural and socio-economic background of the patient. And more importantly, as ma'am highlighted, just like exercise, it should be enjoyable. We will have to maintain the pleasure of eating should also be maintained, and eventually we should be able to hand over the reins to the patient so that they will be able to manage their diet in the long run without asking us every time what to eat, right? So before going to the topic proper, I just want to highlight three things which are often used interchangeably, but they are entirely different. Diet pattern is a different thing that refers to the totality of all foods and beverages that we consume over a period of time. For example, a Mediterranean diet or a low carb diet, low fat diet is a pattern, right? And diet plan or simply diet is an individualized guide how we make the patient when, what, and how much to eat, how we tell them. So that is called as plan. And approach is how we fit that pattern into your diet plan is the approach. For example, your portion control or the plating method, all these things is an approach whereby we try to incorporate the pattern that we feel is right for the patient into patient's routine meal plan, right? So first coming to carbs in diet, as you all know, it's a major macromolecule in our food across the globe, irrespective of our ethnic difference. Why? Because it's cheaper, readily available, and it is the preferred fuel source of our body. So the pleasure that carbs give, no other things give, at least in the long run. So, and of course, for diabetes point of view, it's a major determinant of postprandial blood glucose. And I'll be talking about three things: this so-called low versus high carb. What is that, and what is the evidence behind that? And carbs, what are the current global guidelines say, how we can adapt these guidelines in our population. When I say our population, in Tamil Nadu I would say. So low versus carb, where to draw the line, right? So most macronutrient distribution across the globe, they say that majority of the population consume around 50 to 60% carbs in their routine diet. So when they say low versus high, it's actually when you have the same, when we don't intervene and let the patient eat the same amount of carb as per their routine general population, we say it's high. And whenever we make an effort to reduce the carb proportion or the energy proportion from carb, that is low. When we make it very low, that becomes ketogenic. So this is a global cutoff or definition. There is no consensus, of course, because most of the studies will be employing this cutoffs usually, right? So there is a thing, and this is what I was trying to highlight. High carb. When we say high carb, the usual carb. It's not essentially high carb. We are not spiking the carb. It's actually the usual carb intake of that population. And we say low carb when we take any effort to restrict the usual carb intake of that population of varying magnitude, right? So when you are trying to manipulate this macromolecule, there is something called as nutrient displacement. When you are if you want to lower your carb, naturally the fat and protein portion will go up. So that is called as nutrient displacement. So when we say high carb, that means it's essentially low fat. When we say low carb, it's essentially high fat. So these are some confusing things which I came across when preparing for this talk. So I thought I will keep the ground clear. So there are a lot of RCTs, good RCTs, but comparing low carb versus high carb for glycemic benefit in patients with type 2. But I chose this one because this is the longest running, probably longest RCT conducted in this topic, and they ensured that a lot of confounders were addressed. For example, the low carb and high carb arm, they kept their calories constant. Other lifestyle interventions were similar, and despite the presumed low carb, high fat intervention arm, they kept the saturated fat even in that arm less than 10%. And most of the patients were provided foods, and attrition rate for a diet study is reasonable. So for all these reasons, I thought I'll highlight this one RCT among all. So this is the low carb arm or the low carb high fat arm. 14% carb from total 14% of energy were derived from carb. In the high carb arm, it's the usual cap, 50% carb. So this was the intervention they did. And what they found at the end of the 2 years RCT, there was absolutely no change between low carb and high carb or the low carb versus the usual carb in terms of the primary outcome, that is reduction in HbA1c, fasting blood glucose, weight, body fat, BP, LDL, flow mediated dilatation, a marker of endothelial dysfunction, renal status, all these are secondary outcomes. There was absolutely no change between the two arms. But in low carb arm, there was significantly lower anti-diabetes medication usage, and they did the 7-day CGM constantly in that study, and they found that there was a significant reduction in glycemic variability as well. So probably in the long run, the low carb arm might have derived some more benefit, even though the study did not met the primary outcome. So again, coming to the latest RCT in this topic, the low versus high carb for patients with diabetes, is from UK. It's a systematic review that included 48 RCTs. So again, similar results in terms of HbA1c, fasting plasma glucose, and serum triglyceride. At the short term, for at 6 months, there was some reduction compared to the high carb arm, but in the long run, none of them materialized. Other things remain constant between the two arms. Again, remission is something which all of us have been talking a lot about. So I'll again the same point: low versus low, very low carb diet for remission. Again, review of meta-analysis. This is an RCTs that compared low carb versus very low carb that ran for at least 12 weeks were included in this meta-analysis. And again, they found that at 6 months, the low carb diets achieved nearly 32% better remission rate compared to high carb diet. But the definition of remission that they included was that whether the patient is good control with diabetic medication. It was not without diabetic medication. So when the actual remission definition was applied without diabetes medication, there was no change or minimum change. Again, the partial remission that was seen at 6 months also lasted 12 months. And one more thing I would like to highlight is in this study, in this meta-analysis, they noted that patients with very low calorie diet or very low calorie diet actually did not have poor adherence, and in the long run, it was less effective for weight reduction compared to the low calorie diet. And at 12 months, the quality of life in those with restrictive diet also went down. So, based on all these things, the current guideline, what they say is that there is no clear data to recommend lowering of proportion of carb in patients with diabetes compared to general population. When they say the guideline, it's actually American, UK, and most of the global guidelines say so. So there's absolutely no difference. And there's no ideal percentage of calories from carbs, protein, and fat for people with diabetes. And they eventually had this fancy, catchy line that people eat foods, not macronutrients. People don't eat carbs, they eat foods. So probably it will be better off talking about the individual foods rather than talking about carbs, fats, and confusing them, like I'm trying to do with you people. Right? So focus on quality of carbs and portion control rather than this macromolecule is the ultimate buzzword that these guidelines are giving about, right? So what are the RSSDA sites? I think only sir is RSSDA guy. He's there in every RSSDA meet. So they have a fancy table, beautiful table, and this is what they've written about carbs. Literally, it's the same as the global guideline. Carbs, 50 to 60% of total calorie intake. Complex carbs should be preferred over refined product, and probably they talk about GA and GL and fiber intake. All these things are fine, but for some unknown reason, only rice is mentioned in that table. Probably this dietary intervention trials were mostly published from South India. Probably that made them include include rice in that table because of the Indian guideline, right? I'm all for our one nation, but I believe when it comes to culinary, each of our states it's like a separate country. I'm from Sengote, it's actually stone throws distant from Kerala. But when you walk 10 kilometers to that part, their diet is entirely different than us. So when you talk about the national guideline, probably mentioning only about rice and not mentioning about other staple diet from other states, probably mislead us to think that rice is bad for us, right? Even though what they have written is absolutely true, there is no, contra opinion, but there is something issue with that. So carbs in Indian diet compared to others, this is what I wanted to highlight in my talk. When you talk about global population, 40 to 50% of their energy intake is from carbs. But data from Q study from South India, mostly from Chennai, they says that in our urban population, at least 64% of our major intake is from carbs. So we can, I just did that routine. The most common breakfast that we consume is 3 idlis and chutneys. A person who eats little will be eating 3 idlis and chutneys. Most of our patients will be eating them, and most of us will be eating this kind of breakfast. That will contain nearly 80% carbs. And lunch is little better, 70% carb. And dinner, the standard dinner is dosa with some leftover sambars or freshly prepared chutney. Again, that will contain 70 to 80% carbs, right? So on an average, for a Tamil diet, probably our carb intake is around 70 to 80%. So compared to global figure, we are taking very high carb intake, right? So when you are trying to target a target of less than 50, it's probably too steep a target for us. Probably we will never be able to achieve that target. And if you want to just adopt the global guideline, whatever they have said is don't disturb the carb of the patient, whatever the general population is taking, you try to take the same amount of carb. If you are going to say the same thing, then you will have to say you just take the same 70 to 80% carbs, right? So this adaptation, I think there is some, I thought there is some issue with that, so that I wanted to highlight in my talk. So it's actually low carb diet for us when you target 50%, probably it will be very low carb diet for me who takes idli, dosa and rice a day, right? So should we change, should we keep the numbers same, or should we take the same consensus as the global guidance? It's a little bit confusing to me. So for our population, high intake is 70 to 80%. Anything lower than that will be low carb intake, right? So adaptation, again, I would like to say people eat foods not carb. Probably we will be better off targeting quality of carbs and portion control rather than talking about carbs in our population. Should we universally restrict carb in our diabetic patient because our percentage of carb is higher? I don't know. And if you are trying to restrict, how much to restrict? Should we go to the global general population target of 15%, or anything lesser than 70 should do for us? That is a little bit dicey. So calories and diabetes, the second part, I have only 5 minutes. So unlike carbs, little bit less confusion here. Calories restriction is universally proposed in our diabetic guideline globally, and calorie restriction aids in diabetes control mainly through weight loss. Again, progression of diabetes from pre-diabetes aids in glycemic control as well as in remission. Just to highlight little bit data, DPP study first showed that pre-diabetic to diabetic progression can be reduced if you restrict calories. So they show that even the outcome study or the follow-up study at 10 to 15 years, if you are restricting calories and have produced 7 to 10% weight loss, probably in the long run also the progression rate is lower. The same thing was seen with the Indian DPP study as well. Glycemic control, calorie restriction in established patients with diabetes. UKPDS says that that was the first guideline they showed that when you produce weight reduction, there is a reduction in fasting. But in that study, it was seen that less than 5% weight loss carried no glycemic benefits. So the minimum recommended weight loss in most guidelines is you have to produce at least 5% weight loss for seeing glycemic benefit. How to produce that 5% weight loss? Again, majority of the study says that if you could reduce your calorie by 500 to 750 kilocalorie per day, you can reduce 5% weight loss over a period of 3 to 4 months, right? But now the concept of remission is taking over us. So now they say that as much as weight you can reduce, as much as low calorie you can opt for if the patient is willing to take that risk. So it's more the merrier now, right? So and this umbrella review again highlights that irrespective of the diet pattern that you want to propose, if it is able to reduce calories on a long run, it will be beneficial in a patient with diabetes, and more the calorie restriction, greater the chances of remission of diabetes. So this concept of remission, diabetes remission with calorie restriction came from look-ahead trial from US, bigger trial. Over a period of 4 years, they showed that the remission rate was better than general population. Direct trial again applied the same principle in an extreme way. Again, it was done in a primary care center. They chose patients who are willing to take that risk, and they put them on a total diet replacement targeting around 800 kilocalories for 3 to 5 months, followed by gradual food reintroduction. And they noted that at 1 year, nearly on an average 10 kg weight loss and 46% had complete remission of diabetes. So these two trials were the major evidences behind advocating calorie restriction for remission of diabetes. So for our population, ICMR says that it's the same for general population as well as in diabetes patient. You have to target gradual weight loss, and calorie restriction should not be more than 500 kilocalories per day ideally. And they say that 0.5 kg reduction is desirable, but all these are thin on data, more like expert opinion. So you may think that calorie restriction, probably there is no confusion, but again there is a twist here. There is something called as MNT without calorie restriction, or if you think can a MNT, medical nutrition therapy, work without calorie restriction? So that concept came from this contradicting principles of obesity. So what we know is this energy balance model. If we take more calorie than our need, that calorie will get deposited, and it will eventually make us develop diabetes and obesity. So it is based on law of thermodynamics. The more you take, the more the risk, right? So this is the simple model that we are trying to address with calorie restriction. But there is one another model called as carbohydrate insulin model. It says that some patients are genetically predisposed for developing obesity. Of course, all of you might be knowing. Just to explain that obesity is the cause of excess calorie intake in this population, not the consequence. So they say that a person who is genetically predisposed have some adipose tissue dysfunction. When they take too much of carbs, the too much calories from carbs will make them actually develop diabetes and obesity in the long run. So what are the clinical implications? They say that even when you propose unrestricted calorie diet, if you are able to restrict only carbs in a certain percentage of population who are genetically predisposed for this, for developing obesity, probably we may be able to control diabetes and promote weight reduction in the long run. So proof of concept study from Denmark, they say that in an unrestricted environment, those who take high carb or low carb diet compared to high carb diet, they were able to actually produce significant reduction in A1C and lost more weight at the end of 6 months. So to conclude, carbs and calorie, what to restrict? It's definitely not a straightforward one. Even though that currently probably we may think that we need to restrict both. With regard to carbs, we are still not sure whether reduction or restriction is beneficial in the long run. And if at all we are planning to restrict in our population, how much to restrict is a bigger question. Regarding calories, there is little bit clarity here. Probably calorie reduction in any form, in any dietary pattern is helpful for our patient with diabetes. But probably some individual who will be genetically predisposed, specific calorie restriction from carbs might be able to induce remission or improve their glycemic control. Probably the concept like precision nutrition might take over in the future. So to conclude, apart from all the confusion that I created, I would advocate this one in my setting when I am having a one-to-one discussion with patient. All I try to do is calorie restriction. Calorie restriction will be the base of my prescription. As the ma'am told, just like exercise, diet should also be a prescription. All I do is just get a 24-hour diet recall and sit with the patient. Patient will be able to tell you that he will be comfortable in leaving certain foods. Not that we want them to lose their food, but they will say that I can leave this one, I can leave this one. For calorie restriction, that is the simplest way to sit and discuss with the patient. If you sit and do that, hardly it may not take more than 5 minutes. Apart from on top of calorie restriction, the second idea or second easy way to ensure MNT application is portion control. And we can improve the quality of carbs. Just like prescription wise, we can take fruits 2 or 3 times per day. So when we make them eat 2 or 3 times fruits per day, it will automatically ensure that other forms of carb will go down by the concept of nutrient displacement. Carb restriction, I'm not pretty sure. Probably a younger individual who is very keen for remission, I may ask them to go for a restrictive carb diet, but I'm not sure that is universally applicable in all patients, right? Thank you.
Thank you, Arun. So a clear message to us is very important than carbohydrate restriction. That is the point we want to tell. Yes. So any questions? What about this paleo diet? Mediterranean
Yes,
diet?
as I told, again it works with calorie restriction. What do you think paleo diet actually you're making the patient depends on the ketones that we produce by restricted diet, right? Again, they say that in the long run, it's only the calorie restriction that is showing that kind of dramatic effect. Ketogenic diet, some of the guidelines, global guidelines, even prefer ketogenic diet for a short time. Italian Society of Diabetes says that probably a 12-week course of ketogenic diet can be prescribed for many patients. So it's again prescribed.
Age restriction for this paleo diet, because few old patients also are coming to me with knowing this paleo diet. Is there any restriction? Because complications of paleo diet like renal stones and high uric acid, all these things are occurring.
I'm not sure there is an age cutoff for application of ketogenic diet, but if you ask me, I won't recommend ketogenic diet for any of my patients. Probably if they say that I'm going for ketogenic diet, I'll just caution them regarding the adverse effect. I think we as people who treat diabetes, we should not promote medicated diet, because the next day somebody will say, bring out some guideline or some data showing that this diet has some drawback and will be in the soup. So overall calorie restriction rather than commenting or rather than enforcing some pattern diet will be good for us.
Micronutrients, what about this? Do you need vitamins or do you need this supplementation of micronutrients?
Yes, sir. Again, globally they say that no micronutrient replacement is beneficial in patients with diabetes. But when you are opting for a too restrictive diet, or the patient himself is coming with a very restrictive diet, probably we may need to supplement few micronutrients.
So multivitamins are not necessary for diabetes. Okay. So calorie is very important than carbohydrate. That is the two things what we learned from this discussion. Any other questions?
Only one message. Beautifully covered everything. We were highlighted an important point. Tamil people, Tamil Nadu, 70 to 80%. Absolutely right. In Dindigul and Madurai, biryani is very famous, where 80 to 90% of energy is from carbohydrate in Dindigul and Madurai. Our people, simple thing. I asked them to cut down one dosa or one idli or one puri. There is very enough for those people to bring down their blood sugar very easily. So in our part of the country, advising them to reduce the calories really helps. Thank you.
So again, the biryani part, I don't think biryani is 80% carbs. Biryani is probably only 60% carbs and 40%
Actually,
fat.
biryani in Dindigul, they mix with a lot of this gravy, all those things. It goes up to 80-85%.
Thank you so much. That was a really interesting topic and timely topic. I would like Dr. K. Muralidharan to felicitate our speaker.